And now it's my pleasure to introduce Daniel Carlat. Dr. Carlat is a practicing psychiatrist who also serves as an associate clinical professor of psychiatry here at Tufts University and is an active mental health journalist. He is the editor-in-chief of the Carlat Psychiatry Report, a peer-reviewed newsletter on psychopharmacology, and his blog, the Carlat Psychiatry Blog, has received an award for outstanding mental health journalism. And he has also written for Psychology Today, the Psychiatric Times, and the New York Times. His new book, Unhinged, takes aim at his profession and asks the question, is psychiatry fulfilling its essential purpose? While the goal of psychiatry and its related fields ought to be to understand and heal mental illness, Dr. Carlat argues that overemphasis on prescription drugs and de-emphasis of talk therapy have shifted the goal from to the simple treatment of symptoms.
Thank you very much for coming out tonight. And as Rachel was talking about all the blogging that I've done, as I was browsing, I saw a book that said, What the Internet Does to Your Brain, and I'm thinking, wow, this is really what the Internet has kind of done. Is creating this book is what the Internet has done to my brain. So I was at I was in New Orleans recently at the APA meeting, the American Psychiatric Association annual meeting, and I got a taste of just how angry it's possible to make some people that are in your field when you are critical. I mean, there's been a lot of books out that have been somewhat critical of psychiatry, and typically they have not been written by psychiatrists. When you're a psychiatrist and you become critical of your field, you're in for kind of special retribution. And so I was walking around the booths, the publishing booths at the APA meeting, and there was a woman who's quite a big wig in the field. She's written textbooks in child psychiatry, and she's used to edit one of the journals in child psychiatry. And I went up to her to introduce myself because I just started a newsletter in child psychiatry. I wanted to just sort of show it to her and see what she thought. So she took one look. I said, "Hi, I'm Dr. Carlat. Nice to meet you." And she took one look at my name tag and said, "Oh, I know you." And there was something in her face that was a little bit hostile. So I said, "In a good way or a bad way?" And she said, "Well, in a bad way, to tell you the truth. You, in your New York Times article, trash your training at Mass General Hospital, and then you say that you came to this realization that you had to understand your patients. Meanwhile, you're writing these articles in order to sell your books and your newsletters." This is all at high volume with about 20 people waiting at the table. Meanwhile, of course, she's signing her own books. So that was lost on her. Anyway, so I walked away, and one of the women who was waiting in line stopped me and whispered to me, "I get your newsletter, I really like it." She was waiting in line too. Anyway, so in the small world anyway of my fellow psychiatrists, this type of book and the type of articles that I've written generate a lot of controversy. Because essentially what I'm arguing in this book is that we, as a field, are providing substandard care to our patients, even though there is a hierarchy in psychiatry, just like there's a hierarchy in authors. You know, Sebastian Junger gets paid $5 and he gets to go to the Brattle Theater. I'm here for free. But just like there's a hierarchy there, in psychiatry there's a hierarchy. You have the psychiatrists who prescribe the medications. For those who don't know the difference between a psychiatrist and a psychologist, psychiatrists are the ones that go to medical school and prescribe the medications, and the psychologists are the ones that go to psychology graduate school and are not able to prescribe medications. So for years now, people in my field have developed something of an elitist attitude vis-a-vis those who are in other fields, who are the therapists. And that kind of attitude is something that I think I absorbed by osmosis while I went to do my residency. I did my residency nearby here at Mass General for psychiatry. I did medical school in San Francisco. But it was something that I kind of absorbed by osmosis, having started my residency in 1992, which was shortly after Prozac came on the scene. And this was a time when the medications were coming out at a dizzying clip. And there was a sense in which we had finally gotten it. And there was a sense in which, as psychiatrists, what we could do is just prescribe the medications because we had understood the biochemistry of the brain. And for those messy, messy issues that people have to deal with that could not be dealt with medications, we could just refer them to people like social workers and psychologists. So there was a sense in which, aren't we lucky that now that we have been able to figure out the biochemistry, we don't have to do that stuff anymore. So this was sort of the culture that I was trained in. And it's a culture that I think a lot of people, as a lot of psychiatrists actually, are thinking twice about these days. And the article in the New York Times Magazine that was sort of prelude to this book was called Mind Over Meds. And it was basically an article saying, psychiatrists prescribe too many meds and we don't do enough therapy. And it was really uncontroversial, surprisingly so. And many, many psychiatrists, which was surprising to me, wrote me, emailed me, or left comments on the New York Times website saying, essentially, bravo, I agree with you. In fact, I'm one of the psychiatrists that still do a lot of therapy. And there are many, there may be some in this audience that do, and there are many psychiatrists out there that still are able to do plenty of therapy in their practice. But the latest figures, these were from about 2005, were that only 29% of all psychiatry visits entail psychotherapy, and only 11% of all psychiatrists offer therapy to all their patients. So something has happened over the past several years in which we have given up therapy and we're doing mostly medications. But let me read a bit from just chapter 1 of the book, which I read from mostly because if there was sort of an awakening that I had in my gradual shift from being a psychopharmacologist, which is the type of doctor that prescribes meds, to becoming more of an integrated practitioner, this woman, Carol, was the type of patient that helped me to shift my way of thinking. So chapter 1 is called The Trouble with Psychiatry. For the last 15 years, I practiced psychiatry in a small town north of Boston, Newburyport, actually. It is a solo private practice. I see mostly middle-class patients who come to me with depression, anxiety, substance abuse, and occasionally more severe problems, such as bipolar disorder or schizophrenia. Like most psychiatrists in my generation, I've specialized in prescribing medications and have referred patients in need of talk treatment to a psychotherapist. During my training at Mass General, I was taught that we were on the threshold of understanding the biochemistry of mental illness. And I'll also say that the 1990s were the decade of the brain, so there was this feeling at NIMH, too, that we were about to kind of unlock all the secrets. After I graduated from residency, I worked hard to keep up with the explosion of neuroscience knowledge, absorbed the intricacies of how to use the new drugs as they poured forth from the drug companies. By harnessing these powerful meds, I thought I was providing my patients with the best psychiatric treatment possible. But a couple of years ago, I saw a patient who made me question both my profession and my career. So Carol, in her mid-30s, had short brown hair and strikingly green eyes, I'll always remember, that were filled with despair. Once we were seated in my office, I asked her, "How can I be of help?" "My father was killed in a car accident," she said, choking back tears. "How awful," I said. "When did this happen?" "Last month." Carol told me that she had been in the car with her father, who was driving. They came over a rise in the road, and another car was just pulling out of a driveway in front of them. Her father tried to swerve, but it was too late. They collided with the other car, and her father, who was not wearing a seatbelt, was killed instantly. And miraculously, Carol was not seriously injured. Since then, she told me she had recurrent dreams about the accident and couldn't prevent herself from replaying the scene throughout the day over and over again. The events would unreel themselves like a movie in front of her, and often she would start sobbing uncontrollably. These were typical symptoms of post-traumatic stress disorder. She said that she experienced, I asked her a series of questions, she experienced these symptoms. She said her life was constricting inward. She said she drove rarely, avoiding especially the road where the accident had occurred. "Are you avoiding anything else?" I asked. I won't watch TV. I can't read the newspaper. I never realized how many stories there are about car accidents in the news. I asked her about symptoms of depression, and she reported that she had some. She had insomnia, poor motivation, but luckily no suicidal ideation. The worst thing, she said, is how guilty I feel. Why guilty, I asked. It was my fault that we crashed. I got him upset. Her eyes began to well up. I was telling him that he shouldn't be drinking. He was drinking and driving? She nodded. I told him I could smell it on his breath and that he shouldn't be driving. He got mad, started yelling at me, and then he floored the gas pedal, said something like, "Am I driving good enough now?" And that's when it happened. I could see that this was going to be more than just a simple case of PTSD, if there really are such cases that are simple anyway. She would have complicated feelings about her father to wrestle with, grief, regret, and eventually a good deal of anger. I then told her that I thought she had PTSD. I wrote out her a couple of prescriptions of medications, Zoloft, which is a Prozac-like drug, a serotonin reuptake inhibitor, and the tranquilizer Klonopin. And then I reached in my file cabinet and handed her a business card. And this is a good therapist who I often work with, I told her. I recommend that you give her a call and set up an appointment. The medication works better when you're also seeing a counselor. She looked confused. Aren't you my therapist? I shook my head. Unfortunately, I don't have time in my practice to do the therapy. I usually refer my patients to a psychotherapist I can trust here in the community. So, am I going to see you again? Yes, I said, we'll schedule another appointment in about a month to see how the medications are working. But in the meantime, I hope you'll have had a couple of sessions with this other doctor. Carol still didn't look at all happy about this. But aren't there any psychiatrists that do therapy, she said. There are a few, I said, but not many. They're hard to find these days. So Carol left my office, and after she left, I finished writing her note. I closed my chart, put my pen down, and looked out my office window at those white-steepled Unitarian church that's right across the street. And there was nothing really unusual about my encounter with her as I was reflecting. This is a few years ago. I did what most psychiatrists do when they encounter a new patient. I sat comfortably in my red leather chair, wearing my suit and tie. I asked her a series of diagnostic questions. Her answers fit neatly into a recipe book of psychiatric diagnosis called the DSM-4, which is our list of mental disorders. I pieced together a diagnosis that made sense to me. I then reached over to my desk, wrote out a prescription, and handed this to her. Pondering this typical appointment, what struck me most was what I did not do. I am an MD, and it really was not fun going to medical school, I can tell you. Basically, medical school is 12 years of training when you include the pre-med courses in college. So I did my grueling medical internship in a general hospital, my 3 years of psych residency at Mass General. But like most psychiatrists, I did little to take advantage of those years of training. I did not do a physical exam, nor did I take Carol's pulse or blood pressure. Typically what we do in psychiatry is we get the patient's primary care doctor's records to establish that they don't have a physical cause to their distress. Indeed, the only times that I stirred from my chair were to meet her in the waiting room at the beginning and to show her into my secretary's office to make a follow-up appointment at the end. Just as striking to me as the lack of typical doctorly activities in psychiatry is the dearth of psychotherapy. Most people are under the misconception that an appointment with a psychiatrist will involve counseling, probing questions, and digging into the psychological meanings of one's distress. And my sense is that probably here in Cambridge, that's not so far from the truth. It's probably fairly easy to find a psychiatrist here who does do more therapy, but it's not only is it hard to find that type of psychiatrist in most other places, it's hard to find a psychiatrist at all. It's usually a 3 to 5 month waiting list if you can find someone. But the psychiatrist or psychotherapist is an endangered species. In fact, according to the data from Columbia University, as I mentioned, only 1 out of 10 psychiatrists offers therapy to all their patients. Doing psychotherapy doesn't pay well